Hi all, this is a final exam review for you guys to look over in the next week and a little bit. I'm just going to cover some of the main points from the cardiovascular, respiratory, and then the limits to VO2 max sections that we talked about this half of the course. I'll include a little bit on the neuromuscular section as well, but I've talked to Nick and we've thought of a way to include some of that material in the exam. So go back through your notes, and if you have questions about that stuff, send me an email or send Nick an email. We'll get you guys an answer on that stuff as well. So, exam review. To start off, I thought I'd go back and deal with the main variable that we talked about in the cardiovascular section, blood pressure. This is the variable that is regulated and always monitored, that we have to ensure responds properly to exercise. And we talked about how that was accomplished. It's a classic negative feedback loop. Something has to be sensed. The things that do the sensing, we talked about what those are and where those are. It's important to understand why they're set up where they are in order to understand how the blood pressure can be effectively regulated. Next, something integrates the signal, compares what the sensors are telling it versus what it's expecting. And if there's a discrepancy, action is taken in order to bring blood pressure back to normal. So if it's too low, something will be regulated to increase blood pressure, and if blood pressure is too high, something will be regulated to reduce blood pressure. So we get fairly effective regulation by this classic system. This is always operating, and the transition from rest to exercise is a really unique place to investigate how this works, because it changes a little bit as you move to exercise. Now, we talked about blood flow and how it's distributed normally in the body at rest. The big change with exercise is that we get the large majority of blood directed towards the muscle, because this is where tissue is metabolically active. This is what needs to have blood supply in order for exercise to continue, and so a lot of other tissues see a reduction in their local blood flow. This will be proportional to the degree of exercise. So when muscles are more activated, the signals are larger for that muscle to get more blood. You'll notice that we talked about trained versus untrained. There was an issue that trained are able to maintain blood flow to other tissues for longer. So some trained muscle might be able to extract more oxygen from the blood that it sees, or there's more blood volume in total. But overall, trained can keep blood flow up to those other tissues, and that does serve an advantage during exercise. Think about what the mechanisms are behind that. What dictates the response to blood flow? That's actually exactly what we're going to talk about on the next slide. The distribution of blood as we move to exercise is dictated by a fairly unique system. It's really intuitive when you think about it, but we squeeze all of the blood that we can away from the periphery. Step one when we go to exercise is to constrict everything. Just assume that nothing needs blood flow. So this is the job of the sympathetic nervous system, to constrict all of the arterioles, to limit blood flow globally. This seems like a counterintuitive approach because the muscles that are active need blood flow, and why would you ever shut it off? But we get around this because some factors that are produced by those working muscles dilate the vessels in that area and ensure that blood is directed to where it needs to be. Now, you don't have to remember all of this list of factors that the working muscle releases, just the general setup. Everything gets turned off, and then only the muscle or only the tissues that are active will see an increase in blood flow with exercise. Also think about how this could be proportional to exercise as well. when we move to exercise, the sympathetic nervous system is the main driver of the exercise response. And it is proportional to the intensity of exercise. So you can imagine that the degree of constriction would be proportional to exercise as well. And then the rate that these local vasodilation factors are produced should also be proportional to exercise. So we get this inherent scaling ability that's built into this system. Overall, remember that total peripheral resistance decreases during exercise, which might seem counterintuitive after talking about global constriction, but the vascular beds of the muscles open up so much that from the heart looking out, it looks like the resistance to flow has really gone down. Now this is dangerous because if TPR drops too low, then blood pressure will drop as well. And remember, in the back of your mind, that's the thing that we're always trying to monitor and maintain, so we have to do something in order to counteract this decrease in TPR. So think about the equations, and we'll see one on the next slide that might help you. Now, TPR decreases during exercise, and we just talked about how the SNS is proportional to exercise. So it would make sense that the drop in TPR would also be proportional to exercise. So more intense exercise, more of a drop in TPR. So it's a bigger disturbance that the body has to counteract, has to adapt to. And what we see when we move to exercise, even though TPR drops, and in the bottom right-hand corner you can see the equation where if TPR on the right drops, then, well, of course, blood pressure will drop. Even though we see large decreases in TPR, we actually see an increase in blood pressure. So just by looking at that equation, we know that cardiac output has to increase in order for blood pressure to increase. It has to offset that decrease in TPR. And both of these graphs show blood pressure in response to intensity, so across a wide range of intensities, and you'll notice that overall mean blood pressure goes up with intensity, systolic goes up with intensity. But what I find really cool, and I think, well, I hope that you guys find it really cool too, is on the left side, when you move from rest to exercise, we get this initial sharp jump in blood pressure. It's not linear like you would expect with gradual activation of the SNS system. There's a really sharp jump. And it almost seems as though the body is erring on the safe side. Instead of regulating blood pressure around the same level that it always does at rest, as soon as we get this exercise signal, it resets the set point. It starts trying to regulate blood pressure at a higher level, which doesn't make a lot of sense at first, but we know that if blood pressure drops too low, we can't get any flow. We can't continue to exercise. So it does make sense, I guess, that blood pressure would be regulated at a higher level. This is what ensures perfusion, that idea that we talked about where we get blood flow to the muscles that need it. Increasing blood pressure ensures that the muscles are perfused during exercise. So really neat that the tables that the brain uses to compare what the sensors are sending it uses a different set of tables during exercise. Now, some of the key adaptations to exercise that we talked about are, well, fairly obvious. The first one is an increase in cardiac output. The maximal cardiac output that you can achieve increases as you become more trained, and this is due primarily to an increase in stroke volume. We know that it has to be due to an increase in stroke volume because maximal heart rate doesn't change with training. And at any given intensity, heart rate will be lower in a trained person than an untrained person. So the key adaptation to of the cardiovascular system being an increase in cardiac output has to be due to an increase in stroke volume. Now, part of this is due to an increase in blood volume. Part of this is due to increased contractility and the ability to load the ventricles with more blood, increased preload. It's important to understand those things that contribute to an increased stroke volume, but that's the main takeaway point. Now, we also include on this slide an increase in the AVO2 difference. This seems to be an increase in the peripheral effectiveness of the cardiovascular system. But you could argue that it has to do with the muscular side of things as well, because as we've talked about, the AVO2 difference is the amount of oxygen that's extracted from the blood, and that's largely dependent on the pull into the muscle. So it's largely due on the enzymes in that muscle. Now, one important cardiovascular adaptation that allows an increase in AVO2 difference is the increased capillary density. With sufficient training, you get an increase in the network of capillaries at the tissue, which puts more blood in contact with the tissue that's active and allows it the opportunity to extract more oxygen. Now, as we move into the respiratory section, one of the fundamental principles underlying the respiratory section is that of partial pressure. Partial pressure is not the same thing as concentration. It's not the same thing as total pressure. Partial pressure is the pressure of an individual gas as a part of the whole. Okay, so it's based on the concentration and the total pressure. If we look down at the table at the bottom, partial pressure of oxygen, typically in room air, is roughly 20% of the total pressure. Right? The oxygen concentration in normal air is about 20% of all of the gases that make up room air, and so the partial pressure of oxygen would be 20% of the total pressure of room air. All right, so it's important to understand that concept, and partial pressure is what we use when we talk about movement of gases through the body. Now, blood gases can be transported in two main ways. As I say that, I think to the CO2 system, or transporting CO2, where there is sort of a third way, but we'll talk about that in a second. At least for oxygen, there's two main ways that blood can be transported in the body, and that's either just dissolved in the plasma or combined with hemoglobin. And we've talked a fair bit about how oxygen, just because of its chemistry and how it's made up, it doesn't like to dissolve in blood. In fact, we get a very small amount, only 3 mils per liter of blood. But the important thing here is that the amount of oxygen that's dissolved in the blood dictates the PO2 of the blood. Okay, so the amount that's dissolved in the plasma dictates the PO2 of the blood, and that has implications for how much oxygen can be bound to hemoglobin. Now, hemoglobin is a really cool system. It increases the blood's carrying capacity of oxygen 70-fold, 65 to 70-fold. So we have the ability to carry 197 mils of oxygen per 1 liter of blood. Just this massive increase. Now, the PO2 of the blood is what determines how much oxygen hemoglobin can load. So this dictates the saturation of hemoglobin with oxygen. And normally we're really good at saturating hemoglobin. We'll sit in most cases at 98% saturated. So our system works well the way it's set up, which is good. Now, know how oxygen travels throughout the body. Everything is gradient dependent, and so from room air there's a large push to move into the lungs. From the lungs there's a push to move into the blood. From the blood into the muscle, and then from the muscle to where it's being used inside the mitochondria. Everything here is really passive diffusion by a gradient. We don't force oxygen into the blood from the lungs. We just provide it an opportunity to do that. we put oxygen in the alveoli, which are in contact with the blood, and then oxygen moves passively. We don't force it in. Everything is passive via these pressure gradients. Now, one thing that we're concerned with a little bit with the ability to load oxygen into the blood is this idea of transit time. And we don't ever come into an issue with this at rest, but when we move to exercise, because blood flow increases so much, less time is given for oxygen to diffuse into the blood. So normal transit time, like we see here, is roughly 3/4 of a second. And that doesn't sound like very much, but in most cases, it's more than enough to fully load the blood with oxygen. Even when there's an abnormal response, which is just a blanket term for general disease response, there seems to be enough time to load the blood with oxygen and unload CO2 from the blood. The concern arises when we move to exercise, outlined by this yellow line here. This is just a ballpark, but now we're starting to infringe on the minimum amount of time required to fully load oxygen in the blood. So sometimes we may consider that there's a limitation in the ability to load the blood with oxygen. Start to think about that. When would there be a limitation to loading the blood with oxygen during exercise? Right, during time at altitude. Exactly. As represented by this green line here. Because there's less of a push from the environmental air into the lungs and less of a push into the blood, it takes more time to load the blood with oxygen. And so if we start to exercise at altitude, we might not be able to fully load the blood and might not be able to sustain exercise for a very long time. Another issue that we talked about that is really cool when you think about hemoglobin, despite the sigmoidal curve, the ability of hemoglobin to bind oxygen isn't a constant. Sometimes it'll hold on to it a lot tighter than other times. And normally we think, well, we want hemoglobin to hold on as tightly as possible because we want as much oxygen as possible. But it's different when we shift our perspective to the tissues. At the tissues, we want hemoglobin to be able to let go of oxygen. And sometimes, like during exercise, we want it to readily give up oxygen. And what's really cool about hemoglobin is that in times of higher temperature or when there's a higher acidity, both of these things occur during exercise. Hemoglobin will let oxygen go more quickly. Now these responses typically only happen at the tissue, so at the lungs, hemoglobin still holds on tightly, but at the tissue it starts to release oxygen a lot more quickly, giving us this tailored response to exercise. So it's a way to more effectively deliver oxygen to the tissues. Really cool just physical property of hemoglobin. Now we talked about this transport of CO2 in the blood. This is a lot like O2. There's two main ways, but we've also got this third way that typically delivers or transports the large majority of CO2 in the blood. CO2 can travel in solution, just like oxygen, and it does it readily. It has a high solubility, so it dissolves quickly in plasma. The second point is in loose combination with hemoglobin. That's a typo, but it does bind to hemoglobin not in the exact same spot as oxygen, but it does bind with hemoglobin. So of those three methods, this third one is really of interest to us because it's unique. When CO2 is produced at the tissues, it can be metabolized by this enzyme carbonic anhydrase to make carbonic acid. Now, that acid doesn't like sticking around at neutral pH, so it dissociates quickly into bicarbonate and hydrogen ions. So we see This reaction occurs in the tissues when CO2 is produced, and this bicarbonate then travels to the lungs where the opposite reaction occurs and we release CO2 back into the environment. Now this is a unique way that the lungs can help regulate acid-base balance. So if you increase your ventilation and you hyperventilate, you're getting rid of more CO2. Your body does become more basic. The other reason that this is so cool is that we have the ability to insert hydrogen ions that were produced by anaerobic metabolism. So when the muscle becomes more acidic, that increase in acidity in the blood travels to the lung and pushes this equation more towards the CO2 side, which results in an increased release of CO2 to the environment. We can measure that when we are performing tests in the lab, and that's why RER, which is a comparison of CO2 produced to O2 consumed, that's why RER increases above 1 at higher intensities. Now, ventilation we talked about as being controlled by primarily CO2 in the blood, but O2 in the blood will also exert some minor control. And ventilation is very sensitive to changes in CO2. It's less sensitive to PO2, but CO2 is the main driver of ventilation. But what we also saw is that these don't change during exercise. So how can ventilation change if the things that stimulate ventilation don't change? We see both alveolar PCO2 stays the same across a wide range of oxygen uptakes. Same with alveolar PO2. So something changes ventilation before these things can change in the blood. There has to be some other mechanism, and that's the coolest thing because we know that the system is responsive to these variables, but the ventilation response preempts any changes in these factors. Now this is roughly where we get an increased compensation in ventilation. When you see that biphasic response that we've talked about at ventilatory threshold, or what we've also called lactate threshold, that's indicated here by this line, and you can see that the disproportionate increases in ventilation after this line do somewhat tend to change these variables, but not in the way that we would expect for the increased ventilation that we observe. And so our best guess at what happens when we move to exercise is that there's initial stimulation of ventilation by central command and mechanoreceptors at the muscle. So just the fact that you move to exercise activates ventilation, and the movement of your limbs sends signals back to that central command center saying, I'm moving this much. In the past, I've had to stimulate ventilation about this much, so let's get it to a level that would supply or sustain exercise, and then we'll fine-tune from there. Phase 2 seems to be an increase in ventilation due to the actual metabolism at the muscle. So consumption of O2 and production of CO2 will alter the response up to an appropriate level. And then we get fine-tuning by the chemoreceptor input and changes in temperature. So really cool system that we can preempt. There's a feed-forward mechanism to increase ventilation before the signal is actually there. Now we also introduced this idea, we just talked about it a second ago, but you guys I think have heard about this extensively, the idea of ventilatory threshold or lactate threshold. Those are essentially analogous. You can see the biphasic response where phase 1 is a rather shallow increase in ventilation for a given increase in intensity, and then all of a sudden at some point we get this steep disproportionate increase in ventilation for a given change in VO2. This is the point where we start to produce that excess acidity at the muscle. Those excess hydrogen ions that result in CO2 production at the lung. We also call this non-metabolic CO2. So this isn't so much a point of anaerobic threshold. Ventilatory threshold or lactate threshold is appropriate, but is not a point that indicates that we switch to anaerobic metabolism. This just indicates that there's some flux in glycolysis that can't be dealt with by the mitochondria, that can't be dealt with aerobically. Now, we didn't talk about this at the end of our respiratory section because we didn't have time, but I just wanted to introduce a couple points here. What do we get from this whole section on regulation and ventilation? Ventilation supplies oxygen to the brain and tissues, and it helps regulate pH. That's the role of ventilation. But I wanted you guys to think about a really cool thing, and that's, why is the trigger PCO2? Why would PCO2 be the main trigger that stimulates ventilation if the goal is to deliver oxygen? Why not PO2? And I thought about it, and the reasons that I came up with were that PCO2 is directly related to the work performed. Whereas PO2, it's just related to the aerobic work performed, right? If you're consuming oxygen, it's to do aerobic metabolism and make ATP aerobically. We have no sense of what the anaerobic side is doing. But with PCO2, we get a sense of the anaerobic side because the acidity produced results in CO2 production. So that's one possible reason. The other reason is that PCO2 is very soluble in plasma, so we can get this very quick signal transmission. And there's probably other reasons, and I'd love to hear your guys' thoughts on it, but it's a neat thing that we just kind of take for granted, that PCO2 is the main signal that dictates ventilation, but the job really is primarily to load O2 and deliver that to the tissues. Now, when Nick talked to you guys, the fundamental concepts of the neuromuscular lecture were that as you recruit more muscle, there's a couple ways to do this, and I thought that his depiction of this was fantastic. So the first way would be rate coding, where we increase the signal through a given motor unit to an individual nerve fiber. And you can see that here, where if force is produced, or force is depicted down here on the bottom left, and we start to increase the signal, sending more recruitment signals to that muscle, force progressively gets larger. So that's one way to increase force as we move progressively into exercise. The other way is to increase recruitment. And I apologize, you can't see the word force that got cut off on the left-hand side. But if instead of sending a larger signal, we send more signals, recruit more motor units, then you can progressively increase force as well, because you get this progressively larger recruitment of the same muscle. It's not that the signal is larger, it's that there are more signals being sent to those muscles. Lastly, we talked about some of the limitations to VO2 max, and we identified one study that was really cool in dictating why cardiac output is limiting in a lot of people. So make sure to know this study, or understand this study. It compared single leg versus double leg exercise, and we see that with single leg exercise there's a small muscle mass being activated and a really low requirement for cardiac output. But despite that low requirement, we have a high muscle blood flow compared to the two-legged exercise, where there's a large muscle mass that's active during exercise, a really high cardiac output requirement to perform that exercise, but blood flow is decreased to each leg. It's less in each leg than it is during the one-leg exercise at the same leg work rate. And what does this mean? Does blood flow result in any changes at the muscle? And in fact it does. When we have the one-legged exercise with high muscle blood flow that allows the muscle to consume more oxygen than during the two-legged exercise where muscle blood flow has been reduced and VO2 as a result has also been reduced. And notice this is at the same individual leg work rate. So really cool that we can see as soon as there is a stress or cardiac output is limited, the demand is higher than cardiac output can provide. There's a decrease in blood flow to each of the individual legs, which results in a parallel change in VO2. Now to conclude, and I didn't mean for all of these to show up at once, but we talked about all of these in class on Wednesday, and it's important, I think, to understand why we can list these points here, why we can say that gas exchange may be limiting in trained individuals. So we alluded to that even earlier in this video. Why would gas exchange at the lung ever be limiting, and why would it be limiting in trained individuals? Think about, in theory, why that's possible, and then think about what it is that we tested in order to determine that during our limits to VO2 lecture. Now we just went through why cardiac output is probably the limiting factor in most people. Make sure to understand that. Carrying capacity is not generally a limitation. Sometimes in people who are anemic, or sometimes in people who are anemic, there are ways to improve carrying capacity that do increase VO2, but they're typically illegal. And lastly, the mitochondria and the enzymes. This was the focus of our first half of the course. These typically aren't limiting when aren't limiting to VO2 max in trained or untrained people. Maybe in the severely untrained that have a very low mitochondrial content and enzyme capacity, but typically these are sufficient to match cardiac output. The main reason that we see massive increases in mitochondria and enzyme content during exercise are to increase performance or endurance of the muscle. All right. So if you guys have any questions, let me know. Shoot me an email. I will be in next week if you guys want to make up or set a time to meet. Other than that, good luck studying.